Now we're going into what we call the big story. It's a major current affairs segment where we look at a topical issue right here in this country. Yesterday, you would recall at this time, we were welcoming Minister Chris Tufton, the Minister of Health in Jamaica, Minister of Health and Wellness, having made his presentation to the Sectoral Debate the day before. We had him yesterday talking about, from his perspective, the nation's health. Well, since that time, the opposition spokesman on health and wellness, Dr. Alfred Dawes, has, I would have to say, come out swinging and criticizing Minister of Health, Dr. Tufton, for being what he calls out of touch with the realities facing healthcare workers and users of public health facilities in this country. Well, he has more to say, and we welcome him at this time. Good morning, Dr. Alfred Dawes. How are you?
Hey, good morning, and good morning to all the listeners. I'm good, and you?
Not too bad at all, Dr. Dawes. You have come out swinging and criticizing heavily the presentation of Minister Tufton. In a general way, what are some of the issues that you would have had based on Dr. Tufton's presentation to the sectoral debate?
Well, the main issue I have is that the reality on the ground, what Jamaicans are feeling, the statistics, the health indicators that tell whether or not a country's health system is working, if its population is healthy or not, or the health is deteriorating. All of those indicators and the perception, the experience of people who are using the healthcare system, these are all completely different from the picture that was painted in Parliament. There were a lot of announcements about the mega projects, and this was not these announcements and the claimed successes are not exactly being felt by people. For example, we have seen, and we must commend the government for increasing the health budget 140%. But during that time, you have seen a significant rise in the number of maternal deaths. The maternal mortality rate is the highest in Jamaica than the last time it was this high was in the 1980s, when the health budget was just a fraction of what it is.
Is it the same? Is it the same for
childbirth?
Not
just that, but another key indicator of our healthcare system success or failure is the neonatal mortality rate, the death rate of babies.
Yeah.
That is higher than it was 25 years ago. The infant mortality rate is higher. The death rate for children under age 5 is higher. Now, in countries that are focusing on screening, which we are just realizing that we ought to be screening for cancers and chronic diseases and putting some money there, the death rate for breast cancer has gone down. In Jamaica, it is going up. We don't have any screening programs for colon cancer. The death rate is going up. The majority, about 75% of colon cancers that are diagnosed, they're diagnosed at a late stage, an advanced stage. Prostate cancer, similar thing. So we are seeing all of these announcements and projects and buildings going up. But if you are looking at the purpose of a public health system, which is to take care of the public's health, you're realizing that the public's health is deteriorating even as the spend has gone up.
You speak about the spend a few times. You've spoken about it a few times. Do you suggest then that the government looks at sort of reallocating funds within the healthcare sector?
They have to, because what is being done is a lot of bells and whistles and frills and ribbon cutting, but the root causes of the issues in the healthcare sector are not being addressed. Let's take this court care program, for example. This was touted as a resounding success. There's a bottleneck, there's a waiting list, a backlog of surgeries across the island. I think 1,500 surgeries were cleared under this program. But you have to look at why we had a backlog. It means that more people are coming into surgical clinics than are being discharged. Why is that so? It varies for every hospital. Some hospitals, the reason why they can't operate is that the operating theaters, the air conditioning units keep going down, so that they're having to do only emergencies. In other theaters, it's because they're short-staffed. It could be poor planning in another theater. It could be that Simple things like linen. You don't have a laundry on site, so you have to be sending linen to another facility to be sterilized, and there are a lot of logistical hiccups, which means that cases get cancelled. That is how you get a backlog. So flying in nurses and putting them up in hotels against the advice of all the technical people, and I can confidently say this, that there are very few people who are practicing in the public health system who supported code care in principle, because they were asking, give us the resources and we will do the surgeries. So you fly in nurses and have them do some surgeries, fly in one or two doctors, have them do some surgery, and they go back, and it's a press release, and it's a resounding success. You outsource them to some private doctors, and they've done that, and then you stop the program and say the problem has been solved. It has not, because in a couple of months, the same conditions that cause the backlogs, they persist, and they're going to cause even more backlogs.
Did you get a chance, Dr. Dawes, to examine the proposal Minister Tufton made in relation to sort of a blended approach where nurses, for instance, could work, say, 5 months in Jamaica, maintain the contract, but they could work, say, 7 months overseas? Did you get a chance to examine that proposal?
That is something that could work. It could be piloted, but when you speak to nurses, it's not the reason why they want to work overseas is because a lot of times they want a house and a car. It's a simple Jamaican dream that all of us want. We want a house and a car. And you can address the housing issue by having special NHT mortgages. We know that a lot of times there's a surplus of NHT funds that keeps being raided by the government to fill different deficits, and it spans administrations. But what if you could incentivize healthcare workers by giving them a generational mortgage or giving them lower rates? Or when you're on graduation, on specialization, you give them a key and say, hey, pay off this by working with us and save your money and start your family. Mm-hmm. No, you don't have to physically bond them, because they're bonding themselves, because they're living their dreams, they're closer to their families. And when you talk to a lot of nurses who migrate, it's rough overseas, but they want to come back because home is really where their heart
is. Yeah.
But it's just that they can't realize their dream working under these conditions. Maybe you want to set up public-private partnerships within the hospitals whereby people who can afford to pay, they'll pay to jump the line and get their surgeries done. Or they want a private room, and they'll pay for that private room, and that can be used to supplement nurses' incomes. So there are multiple ways you can look at it, and I don't think it is going to be a magic bullet solution that you're going to find. It may be a combination of the 5 months, 7 months program, a more special incentivized mortgage, supplementary incomes locally through private-public partnerships. So it's you can't just look at it and say this is the way we're going to solve the problem, but be open to ideas and don't discount the input of the technocrats.
And even the opposition, for that matter. Now, the matter of resources is a big problem for us as a developing country. Are you satisfied with what you've heard in terms of the allocation of resources to possibly increase the ICU capacity in Jamaica?
So, the first thing we have to ask about ICU spaces. Before COVID, we got a number, and it was supposed to be in the 30s, but in reality, it was less than that. It was probably like 20-something ICU beds. We got donations of dozens of ventilators from international partners, dozens and dozens of ventilators, lots. We had increased funding because everybody was concerned about ICU spaces with COVID. And yet, at the end of COVID, we had the same number of ICU beds prior to the pandemic, prior to this massive infusion of cash, prior to all of these donations of ventilators and monitors, etc. So where are all of these ventilators? Why haven't we increased our ICU capacity? Not to look down on another country, but when I'm seeing the footage in Gaza where they're talking about this poor, desolate country and the attacks on the hospitals. When I looked at those hospitals, there's no public hospital in Jamaica that looks like a hospital in Gaza, even after the bombing. And it speaks volumes because it shows that is a significant misallocation of resources, and there's a lot of lack of accountability in the public health care system. Why we will be getting donations, we'll be getting money earmarked for certain projects, and yet we don't see these projects come to fruition.
Are you making
the consequences are significant because when you now have a shortage of ICU space, the grandmother or grandfather who has a stroke or a heart attack is going to be sidelined because you're going to have to choose the young trauma victim because they have more years ahead of them. And it's a tough decision that doctors have to make every day. Who gets to live and who gets to die because of a lack of ICU space. Are
you calling then for greater accountability and even transparency in how healthcare funds are allocated?
We have to. I mean, the Ministry of Health along with the Ministry of Education were two of the ministries involved in this $1.3 trillion, 10 million, almost 10 million US unaccounted for over the last couple of years. $1.3 trillion. The Auditor General just could not sign off on it. Where is all of that money? Why isn't reports being made public? Why can't simple questions like, where is the budget for Cornwall Regional? Where are the allocations? We don't know. But what we do know is that we're pouring in a lot more money into health. But we're not seeing an increase in our improvement in the health matrices that matter.
I think we've spoken about this before, but I wanted to pick your brain on it this morning again. The whole matter of the possibilities in terms of public-private partnerships. Do you see that as an area that we should really try to explore to a higher level?
I think we should, but not in the current format where there is outsourcing, because the government has the advantage of dictating prices because of the volumes that it can send to private partners. But I don't think we're using that leverage enough. I think that in a lot of instances we are overpaying private contractors and giving them a lot of volume. If we're going to do a public-private partnership, it really and truly should be through a national health insurance. And if the partners want to take the health insurance coverage that with the limits, then it is capped, just like you would have Medicare and Medicaid in the U.S., which are government funded insurance, but they cap what the private providers will be paid. Now, if you want to buy into that system, that's fine. You'll get a lot of volume, and then it will be financially worthwhile for you. But at the same time, it caps government spending. But as it is right now, the situation where you're supposed to have a CT scan at a hospital, but then if the CT scan goes down, which happens a lot, you have to pay for that patient to have that scan done externally, and it's at market rate, which can be, significant.
All right, Dr. Dawes, I think we're pretty much out of time. We're going over time, but I want to thank you again for coming on and expressing yourself and highlighting some of the